first of all, most of you may already be familiar, but what is radiation? Just to get rid of some of the assumptions, radiation does none of these. Okay, it's not painful, does not make you glow in the dark, and does not make you a superhero either, to my disappointment. But what it is it's everywhere. Radiation is everywhere. You go fly on the plane, you get cosmic radiation. Winnipeg is particularly noted for having lots of radon in our basements. You know, in our bodies, we have actually radioactive potassium. If you ever buy certain granite counters, it actually has an inherent radioactivity. So radiation is everywhere. What the radiation that we're interested in radiation oncology is the high energy X-rays and gamma rays. And these radiation has enough power or energy, so to speak, to damage the DNA in the cells. So the radiation can either directly damage the DNA through photons or could indirectly damage the DNA by generating oxygen radicals. So the normal cells can repair themselves much more effectively than cancer cells, and that's what the inherent difference of these radiation treatment can do. And the cancer cells die when they try to divide, which is a reproductive cell death, or they undergo a programmed cell death called apoptosis. The therapeutic radiation is delivered by these large machines that are called linear accelerators, and essentially what they do is they take electricity and generate radiation. We have 8 of these units in Cancer Care Manitoba here in Winnipeg and 1 unit in Brandon. And the way radiation is delivered is that it's for a single course of radiotherapy, it could either be 1 day or it could be as much as 9 weeks. It really depends on what the intent of the treatment is. And why do we divide our radiation treatments? For the simplest matter is the dose that we require to deliver to do anything significant is quite high. To deliver it in a single dose is actually lethal. So we divide it up into separate fractions, as we would call it. And because radiation does not involve any type of surgery, any type of needles, it's a non-invasive treatment. The way I see it in terms of the role of radiotherapy in bladder cancer, it's divided into 4 categories. One is bladder preservation or bladder sparing. This is for curative intent. And the second category is for curative intent as well, but for patients who cannot undergo the surgery, the radical cystectomy. The third role is the role of radiation after surgery, and I put a question mark there because that issue is controversial, which I would explain later. And lastly, for patients that has metastases or are incurable, radiation plays an invaluable role in palliating symptoms. So Dr. Drachenberg talked about radical cystectomy as well as Dr. Gingrich, and right now radical cystectomy is considered the gold standard of care. Actually, neoadjuvant chemotherapy followed by radical cystectomy is considered the gold standard of care. Radiation, actually, the chemotherapy and radiation actually has, based on our studies, have equivalent survival rates compared to radical cystectomy. But we don't actually have any randomized or high-level evidence that compares the true treatment modalities head-to-head. Back in 2007, in the UK, they did a trial called the SPARE trial, in which they compared chemoradiation to spare the bladder versus radical cystectomy, removal of the bladder. And unfortunately, this trial closed due to poor accrual. They actually spoke to more than 800 patients in 30 months, but only managed to recruit 45 patients. And when they analyzed what are the reasons why the patients are not agreeing to the trial, surprisingly, it turns out that when patients are presented with a trial that says, we're going to randomize you to a treatment that's going to remove your bladder and a treatment that's going to save your bladder, most of them chose to save their bladders. Not surprisingly, right? It's surprising to us considering that we say that radical cystectomy is the gold standard. We would have thought that patients would have thought, I want the gold standard treatment. Now, can we achieve cure or treat bladder cancer with radiation alone? The quick answer to that is likely not. back in the 70s and 80s, before the modern techniques of cystectomy were developed, radiation alone for treatment of bladder cancer is very common. And in those studies, it showed that the outcomes were not great. Local failures up to 70% of the patients, and the overall survivals were also in the range of 20 to 40%. However, in the modern era, one would think that with proper selection, with patients with maximal TRBT, meaning a complete resection of bladder tumor, it will optimize the treatment, and also picking patients with good performance status will enhance the outcomes from radiotherapy alone. But that's not the standard right now. The standard right now is radiotherapy with chemotherapy. And the standard chemotherapy agent that we use right now is the Cisplatin, which is a radiosensitizing agent. What Cisplatin does is it actually, when the radiation damages the DNA, it kind of fixes or makes permanent the damage that the radiation caused, so the cancer cells can't repair it even further. So that enhances the effect of radiation. And with Cisplatin, we see very good survival with radiotherapy and chemotherapy. We also see good survivals with no recurrences of the bladder cancer. And in intact bladders as well, the survivals are good. Pelvic failure rates are low. And more significantly is no patient required cystectomy because of bladder morbidity, because that's a major concern when a patient goes for a chemotherapy and radiation. If you're going to damage the bladder bad enough and you're going to lose your bladder, why go through that course in the first place? And we haven't really seen that. Of course, that statement may be a bit misleading because it doesn't mean that the patient has a permanent Foley catheter. We don't know that. So one of the other agents that has been explored is 5-FU and Mitomycin C. There are also known radiosensitizers for other cancers like anal cancer. And the reason this was explored was because a lot of times patients that have bladder cancer also have bad renal function. And if you have bad renal function or borderline, you're not a good candidate for the cisplatin chemotherapy because that chemotherapy can damage the kidneys. So this is a good alternative. And what it is this study was recently published, and it compared 5-FU and Mitomycin C with radiation versus radiation alone. And this was published in 2012. And it showed that it decreased with the chemotherapy and radiation, you have less recurrence, you have improved local regional control, but no survival benefit. The toxicity associated with this regimen is different. There's more GI toxicity, which can be concerning because the radiotherapy to the pelvis and to the bladder inherently has increased GI toxicity, but it provides an alternative. Now, what this study doesn't address, and it was a bit surprising that it did not address it, is that is it better than cisplatin? It just provides an alternative, but it does not compare it with cisplatin. Now, radiation for cure means delivering radiation to the pelvis up to 45 gray. That's the unit that we use for radiation. And from a patient perspective, that's 25 fractions, 25 treatments every day, 5 days a week for 5 weeks. And then we boost the bladder up to 65 gray. And then if we can see a bladder tumor or know where the bladder tumor used to be because it's been cut out, then we can also potentially boost that area to 70 to 80 gray. These are very high doses. And of course, ideally, for a cure, this should be given with chemotherapy. When we're going for a bladder preservation or bladder sparing approach, proper selection of patients is very important. Previous studies that showed poor outcomes with bladder sparing approach did not select patients properly. What patients do we want? Patients that, of course, are good performance status, but also have disease that is localized in a single spot. If disease is everywhere in the bladder, it's harder to control. Smaller tumors, less than 5 centimeters. We don't pick patients that have hydronephrosis hydroureter because that implies that the tumor is bulky. And also, patients have to have good bladder function. Why save the bladder if the bladder isn't working in the first place. And of course, a bladder that we're able to remove the tumor fairly completely. So about the bladder sparing approach diagrammatically essentially means undergoing a maximal TURBT and then getting 45 gray to the pelvis and the bladder. Now, then what's important is at this point in time is a cystoscopic assessment be done. In the past, there used to be a planned break of about 3 weeks up to 6 weeks to get this cystoscopic assessment done. And what do we want to know? Well, is there a tumor that has grown back or tumor that's left behind? Nowadays, we pre-arrange it. There's no significant break because we know in radiation, breaks are not good. So if we do not see a visible tumor, then we proceed into delivering the rest of the radiation treatment up to 65 gray. However, if we see visible tumor, which can happen in approximately 20% of patients, then the choice now is to go for a cystectomy with an ileal conduit because the implication of having a tumor is that the radiation and the chemotherapy isn't working, and you need a more aggressive approach. Why ileal conduit? Because the amount of the bowel that gets radiated makes it difficult for the surgeon to do a neobladder. And actually, at this point in time, it's also the best to intervene because 45 gray to the bowels will still allow the surgeon to work with the bowels without significant morbidity. Whereas if we've delivered a 65 gray, it'll be more difficult for the surgeon. So if the entire radiotherapy has been given, what's next? Well, surveillance. Dr. Drakenberg touched on that as well as Dr. Gingrich. And if there's a durable response in the bladder, then that's great. There's nothing else that needs to be done. However, we can see local relapse in the bladder. Now, it could be the occurrence of the actual cancer, or it could be the radiation causing the generation of another bladder cancer, what we call field cancerization. Now, that's harder to prove or to actually say, but it's one of the theoretical weaknesses of treating bladder cancer patients with radiation. Now, if there's a local relapse in the bladder, first of all, we check, is it invasive or non-invasive? If it's non-invasive, we treat it with superficial treatments like the BCG that Dr. Drakenberg mentions. Or if it's invasive, then salvage cystectomy is necessary. So essentially the question is bladder sparing successful? If the goal is to leave the bladder intact, then the answer is yes. Overall, 80% of patients have an intact bladder, and basically no patients lost their bladder due to morbidity. If you included the patients, the 20% that could not complete the radiation that had to go cystectomy, then the number is really 50%. And in all the series of bladder sparing, the survivals are comparable to radical cystectomy data. Now, here's another of the problems with going with the bladder sparing approach. You would think as a radiation oncologist, I'll be selling my radiation, but I can't, because partly is the data on neoadjuvant chemotherapy. If the survival for cystectomy and chemotherapy radiation is deemed to be equivalent, and then we have this meta-analysis that showed that chemotherapy adds on to it, then I cannot say that my chemoradiotherapy is better than chemotherapy and surgery afterwards. And that's what the disadvantage of going for bladder sparing approach. Now, I make a distinction between definitive chemoradiotherapy and bladder sparing in that definitive chemotherapy are for patients who are medically unfit for surgery or for patients who decline radical cystectomy. And for the most part, my practice consists of these type of patients. And so instead of getting that cystoscopic assessment after 5 weeks, they just go for their whole radiation course, and they have a cystoscopic assessment after the radiation. And if there's a tumor visible, then a discussion has to be had about the importance of a cystectomy at that time. And outcomes from this, well, it's good. And for patients that go through entire chemotherapy and eventually have to have cystectomy, even though they declined it in the first place, the outcomes are better than those that are unfit for surgery in the first place, which makes sense because their conditions were poor in the first place. Now, with regards to the issue of radiotherapy after surgery, that actually has become quite a common question that for the past few months. And even though we would like to be able to offer radiotherapy, because inherently we think that radiotherapy can sort of sterilize the area, especially when there is a positive margin or a possibility of microscopic or gross disease left behind. In our literature, there is no evidence to support the use of this type of radiation after cystectomy. And this was actually the text from a textbook in 2008. And essentially, when you go through the literature, there's paper after paper or review after review that says we should, but there is no data. There's no publication that showed that it's there. And if you look at this, this is a grade D recommendation. Grade A is the highest. Grade D, nobody's happy with a grade of D. So this is something that we take very seriously. And why? It all comes down to this particular study that was published in 1992. This study took patients that had radical cystectomy, and there's about 78 of them, and 40 required radiotherapy. Overall survival data is great. It's 67% at 5 years. However, bowel complications were very high, 37% versus 8% in patients that did not get radiation. And more significantly, 3 patients died because of the bowel complications. That's essentially put the lid on it. Everybody got spooked, and nobody wanted to do it. Now, the main criticism of this is an old study. You know, the treatments, the methods, the techniques of radiation back then are old, they're outdated, they're crude. You can use whatever obsolete term you use. But the thing is in medicine, we're very conservative. First principle, do no harm. And so we move very slowly in trying to apply our modern principles in trying to address this question. Now, for the issue of palliative radiotherapy, radiation is very effective. It's very effective for relieving pain and hematuria. And there's various treatment courses that are available, up for single fraction or 3 fractions and 10 fractions. It really depends on the size of the tumor and in terms of the patient's performance status. What practically does a patient go through when they are candidates for radiation? Well, after seeing a radiation oncologist, they go through a CT simulation, which is really just a regular CT scan. But we use these CT scans to contour or outline the target volumes and the organs at risk and plan your radiation. And then you go for your daily treatment. This is the field that illustrates the area that you treat. When I mentioned that the pelvis is being treated, this is the pelvic area that we're treating. And you can imagine this area here there's a lot of bowel there that can have significant toxicity. The technique that we use is what we call 3-dimensional conformal radiotherapy. What it means is basically we take the volumes that we draw onto the CT scan, and radiation is delivered and conforms to that target. We deliver a high dose of radiation to the target and minimize the dose to the organs at risk, which in this case would be rectum, the hips, and the small bowel. How do we achieve this? Well, there's metal leaves in the head of a linear accelerator called a multi-leaf collimator, and essentially they can move and shape the radiation beam so that it conforms to the target. A more advanced treatment modality, which is also available in cancer care more recently, is called intensity modulated radiotherapy, or IMRT. And the MLCs not only can modulate the shape of the beam, but you can also modulate the intensity of beam. So with 3D conformal RT, you can generate a picture that is just black and white. With IMRT, you can do shades of gray. So this picture of Einstein, actually on a radiographic film, is generated using IMRT, just to show you the versatility of this technique. And the key thing about this is it can shape the radiation much more tighter around the targets and spare the normal organs. This idea of using IMRT actually started in the 70s, but back then they lacked the computing power to generate these plans. As it is, for more complex plans, we sometimes have to leave the computer overnight to calculate the plans. But for more simple plans like prostate, a few hours or a few minutes would suffice. So this is sort of a way to illustrate what 3D conformal is. This is a treatment to the prostate, and there is 6 beams, and you can see it's shaping each beam according to the shape of the target. However, with IMRT, those leaves aren't static. They're moving around. So you can focus on, like for example, in this one corner, it's staying put in one area more, so you can get more radiation in that area. So we're able to shape the radiation much better. So what does it result? Well, here you can see the red line means the 100% isodose line, or the radiation, and the purple line, I'm losing my mouse. Oh, the purple line is the target, the purple colored area there. And you can see with IMRT, it's hugging that target, whereas in 3D conformal, it's a box. It's more significant lower in the pelvis when the area that we want to treat is a concave or like a horseshoe. So you can see that we're actually sparing more bowel with the IMRT techniques. And here, we're sparing bowel here, and we're sparing rectum. So that potentially can alleviate the problem of increased complication with radiation. So IMRT results in less toxicity, but the question is would it improve disease control? That really depends on, is the cancer a type of cancer that by increasing the dose you improve the outcome? We know that of prostate cancer. We still don't know that of bladder cancer. Another issue with bladder cancer is the bladder moves. You know, if we tell a patient you need your bladder empty every day, symptomatically, or what they feel, it's empty, but when we scan them, they're probably different every day, most likely going to be different every day. So how do we address that? Well, we address that by making our fields bigger. We make sure that we don't want to miss the target. But if we do that, then we might as well negate all the benefits of IMRT because we're making the target bigger. So our next advancement is image-guided radiotherapy, in which we have the ability to image the patient on the actual linear accelerator, so we know exactly what the state of their anatomy is in soft tissue, and that can reduce setup error and variability, and we can reduce the size of our radiation fields and theoretically reduce toxicity. The latest and the greatest in cancer care right now is what we call rapid arc IMRT. A lot of the radiation that's delivered, even in advanced centers here in Canada, is what we call step and shoot. So basically, the linear accelerator moves on position, it stops, it delivers the radiation, moves to the next position, stops, delivers the radiation. With rapid arc IMRT, if you're the patient lying on the couch, the linear accelerator moves once around you, one arc, and the radiation is continuously being delivered, and it takes 1 minute. So it's the fastest way of delivering the radiation. Why is that significant? Because our organs move. And if we can deliver the radiation fast, we reduce the variability caused by organ motion and theoretically can decrease the toxicity from the radiation again. So the challenges in delivering of radiation inherently in bladder is bladder mobility. So we can address, we can bring out our most advanced treatments, but inherently because the bladder moves, nobody really knows how to address that. We're still trying to figure out, okay, what's the proper margin? What is the best treatment? Do we have to plan the treatment every day? You're looking at 6 weeks of radiation. We can't plan it every day. So that's one of the biggest challenges in radiation for bladder cancer. The other thing is the target volume. For example, after surgery, when the bladder is removed, what do you treat? The whole area has been filled by small bowel. What do you treat? In the past, when we just have what we call open fields, you just radiate that pelvis with no shielding, you're definitely going to hit the target. But now that we're trying to be more precise, now we can precisely miss the target. If a radiation oncologist said, okay, I'm going to treat this, but in reality, that's not the area to treat, we've just missed the target, and that is essentially the worst thing that we can do. So in cancer care, we're trying to address that. First is in the late fall or probably by winter, we're going to fully implement rapid arc IMRT and IGRT for bladder cancer. So that will help reduce the toxicity for patients undergoing chemoradiotherapy for bladder cancer, and also to address the question of whether or not radiotherapy should be given after surgery is my colleague and I are going to institute a phase 1, which is a trial that looks into the toxicity of a particular treatment, a phase 1 trial of adjuvant radiotherapy. Thank you.